Welcome to this high-yield clinical explainer. We're stripping away the pleasantries and jumping straight in to decode the pathophysiology and diagnostic matrices of three critical hyperthermic syndromes. We'll isolate the exact mechanisms, discrete management steps, and the lethal traps that separate these identical-appearing presentations. Let's get to it.
Module 1. Serotonin Syndrome and 5-HT2A Antagonism. We'll kick off this clinical simulation with the serotonin cascade, which is essentially a state of profound receptor overload.
Now, the precise precipitation of serotonin syndrome isn't just a simple overdose, it's an absolute accumulation of serotonin right within the synaptic cleft. You'll classically see this triggered by combining SSRIs or SNRIs with MAOIs. But here's what you absolutely must watch out for. Even seemingly benign treatments, like linezolid for a resistant skin infection, possess potent MAOA activity. Administering linezolid to a patient already on baseline SSRI therapy immediately triggers profound toxicity.
The crucial differentiating point here is the neuromuscular signature. Unlike the other hyperthermic states we'll discuss, you must look strictly for neuromuscular hyperactivity. This manifests as strict hyperreflexia, inducible or spontaneous clonus, and specifically ocular clonus. This absolute hyperkinesia is your definitive physical exam marker that isolates serotonin excess.
Moving to the intervention phase. While mild presentations might just require stopping the offending agent and offering supportive care with benzodiazepines, severe cases are a completely different entity. A severe presentation featuring marked autonomic instability and hyperthermia dictates a strict pharmacological mandate. You must immediately deploy cyproheptadine to aggressively and directly block those overloaded 5-HT2A receptors.
You're often forced to isolate identical-appearing hyperthermic presentations that diverge entirely based on just a few singular systemic variables. Both serotonin syndrome and anticholinergic toxicity present with altered mental status, hyperthermia, and tachycardia. But pay close attention to the distinct systemic variables here. Serotonin syndrome presents with hyperreflexia, profound diaphoresis, and hyperactive bowel sounds. Conversely, anticholinergic toxicity yields normal to hyporeflexic tone, dry, flush skin, and completely absent bowel sounds.
Let's apply this directly to a third-order clinical presentation. Consider a patient on fluoxetine who receives linezolid for a skin infection. They present acutely with a temperature of 103 degrees Fahrenheit, profound diaphoresis, and severe lower extremity clonus. We need to evaluate the definitive next step in management.
You're presented with 5 highly competitive answer choices. You have to definitively isolate the exact receptor antagonist from the sequence to halt the patient's clinical deterioration.
Breaking down these options, cyproheptadine is the absolute mandate here. It specifically antagonizes the 5-HT2A receptor overload. Dantrolene is bypassed completely. That's reserved for ryanodine receptor defects. Bromocriptine is a dopamine agonist utilized for neuroleptic malignant syndrome, so it has zero efficacy on serotonin. Benztropine is a classic trap. As an anticholinergic, it would suppress sweating and fatally worsen the hyperthermia. And finally, flumazenil is completely contraindicated due to the high risk of precipitating intractable seizures.
Module 2. Neuroleptic malignant syndrome and dopamine kinetics. Now, we're turning our attention to central D2 receptor antagonism in the hypothalamus and nigrostriatal pathways. The fundamental defect here is the sudden, massive obliteration of dopaminergic tone. NMS is driven by profound central dopamine blockade. It's typically triggered by high-potency first-generation antipsychotics, like haloperidol or flippanazine, or it can be catastrophically precipitated by the sudden withdrawal of Parkinsonian medications. Either way, this leads to lethal autonomic and neuromuscular disruption.
Unlike the hyperkinesia of serotonin syndrome we just looked at, NMS is hallmarked by severe neuromuscular sluggishness. Your defining physical exam finding is extreme lead pipe rigidity paired with bradyreflexia. This sustained, violent muscle contraction literally crushes the myocytes physically, driving profound rhabdomyolysis. Consequently, you're going to see a markedly elevated creatine kinase, often surging well into the tens of thousands.
Consider this authentic board-style presentation of NMS. A 73-year-old on risperidone presents with severe muscle rigidity, hyperthermia at 103 degrees Fahrenheit, and an elevated CK of 2000. The absolute immediate step is discontinuing the offending agent, risperidone. Notice how the analysis explicitly bypasses anticholinergics like benztropine. Administering that would only exacerbate the hyperthermia by preventing the normalization of core temperature through diaphoresis. detailing the complete intervention sequence. Once the offending agent is immediately withdrawn and the kidneys are aggressively flushed with IV fluids to manage the rhabdomyolysis, you move to targeted pharmacotherapy. The specific pharmacological antidote to reverse the D2 blockade is a direct dopamine agonist, namely bromocriptine, or alternatively, amantadine, to forcefully restore that dopaminergic tone.
To cement this clinical reflex, it really all comes down to clonus versus rigidity. If the neuromuscular exam reveals a patient who is rigid and hyporeflexic, the primary defect is definitively dopamine blockade, pointing straight to NMS. Conversely, if they're clonic and hyperreflexic, you're dealing with serotonin excess.
Next scenario. A schizophrenic patient recently treated with haloperidol develops extreme muscle stiffness, a core temperature of 104 degrees Fahrenheit, and a massive CK elevation of 15,000 units per liter. We must establish the targeted antidote.
Evaluate these 5 distinct options. Lock in your exact intervention by strictly identifying the compromised neurotransmitter pathway driving this specific presentation.
Evaluating the sequence. Bromocriptine is the correct choice. It's a direct dopamine agonist that perfectly overcomes the haloperidol-induced D2 blockade. We explicitly bypass cyproheptadine, which treats the clonus of serotonin syndrome but has absolutely zero efficacy at the D2 receptor. Benztropine is incorrect as it suppresses sweating. Physiostigmine is strictly an acetylcholinesterase inhibitor for anticholinergic toxicity. And naloxone is an opioid antagonist targeting respiratory depression, entirely irrelevant to hyperthermic rigidity. Module 3, Malignant Hyperthermia and Calcium Release Channels. We shift our simulation from the psychiatric ward to the perioperative environment, focusing on a lethal pharmacogenetic defect.
The underlying pathology here is a strictly genetic trap. Malignant hyperthermia is an autosomal dominant pharmacogenetic disorder driven by a specific mutation in the ryanidine receptor, or RYR1, of the skeletal muscle. It lies entirely dormant, just waiting for a highly specific pharmacological trigger to unleash unchecked intracellular calcium.
The triggering event is exposure to halogenated volatile anesthetics like isoflurane or halothane, or the depolarizing neuromuscular blocker succinylcholine. This causes a massive, unregulated calcium release from the sarcoplasmic reticulum. The earliest and most sensitive hemodynamic marker is an unexpected rapid rise in end-tidal CO2 that completely ignores your attempts at increased minute ventilation. This is rapidly followed by generalized muscle rigidity, classically beginning as a masseter spasm and culminating in a lethal spike in core body temperature.
The definitive resuscitative mandate is the immediate cessation of the offending anesthetic gas and the immediate intravenous administration of dantrolene. Dantrolene directly binds to the mutated RYR1 channel, slamming it shut and forcefully arresting the lethal calcium efflux right at its source.
Contrasting NMS against malignant hyperthermia reveals that while both present with catastrophic rigidity and fever, their origins are entirely distinct. NMS is triggered by antipsychotics acting on central D2 receptors, demanding bromocriptine. Malignant hyperthermia, however, is triggered by anesthetics acting peripherally on the skeletal muscle RYR1 receptors, strictly mandating dantrolene.
Let's process one final intraoperative crisis. During a routine appendectomy utilizing isoflurane and succinylcholine, a patient acutely develops severe masseter spasm and a rapidly rising EtCO2. Select the definitive molecular intervention from this set.
Breaking down this sequence, dantrolene is the correct and sole life-saving agent capable of neutralizing the sarcoplasmic calcium storm by binding the mutated RYR1 receptor. Bromocriptine acts centrally on D2 receptors and is totally useless for peripheral calcium defects. Cyproheptadine is a serotonin antagonist with no role in volatile anesthetic reactions. Haloperidol is a potent D2 blocker that would just precipitate NMS. And diphenhydramine is an antihistamine with anticholinergic properties that will utterly fail to arrest calcium-mediated hypermetabolism. This firmly concludes our explainer of these hyperthermic clinical simulations.